We'll get started. Thank you everyone for joining us for this exciting BrainX Community Live event for the November 2022. Thank you all for joining us, and we'll get started with the speaker presentations shortly. To those who are joining us for the first time, we started this community platform 4 years ago with the idea of having this to promote machine learning in healthcare for good. Over these years, we now have 4,000 plus international members. We have a very active LinkedIn group, which has crossed 2,200 members now. So use that opportunity to have communication too. And we have our website. You can go to brainxcommunity.com, which hosts a whole lot of content for you in different formats to help learn about what's going on with AI in healthcare. And you will find the publications related to our today's topic over there too. And of course, we hold these live monthly sessions over here so that we can have the exchange with some of the awesome work that is going on across the world. Again, to show you, this is our website, and we have different sections over here. You can find the updates right on the homepage itself. And then there is a connect section. That is where we put information about future monthly events or the recording information from the prior events, which is also available through our YouTube channel. So if you miss something and you still want to get information about our sessions, subscribe to our YouTube channel, which goes by the name BrainX Community itself, and you will get notification about the event and its video recording directly to you. As I mentioned, we have a very active LinkedIn group. We share a lot of scholarly products over there, publications, meeting opportunities, different content. So please join us over there so that you can also learn and contribute to the growth of this community. We have a Learn section where we provide curated list of publications related to AI and healthcare. We can't provide publications directly, but we provide you the link to the journal. These are categorized based on the healthcare specialty. So you can look over for your favorite one through the filter option. We also have the journal section within the Learn. So you can filter for journals and you can see and select the journals that you would like to follow. And then books. There are a lot of books that are getting published in this field. So you could filter the Learn section for books and see the latest and some real good publications covering AI and healthcare. And of course, everybody is hungry for data. So we provide the largest repository of links to open source data sets so that you can build your fantastic machine learning models out there or validate those. These are, again, categorized based on the healthcare specialty or specialties, and we provide a brief overview directly through our website. And everybody wants to learn from each other. They want to learn from the experts. They want to learn, how they got into this field, what's their vision for the future. So we have our awesome podcast series, which is BrainX Talks. You can subscribe that on your favorite podcast channel, Spotify, Apple, or Google. And you can listen to some of the experts in this field, what they have been working on, why they got into it, and what's their vision for the future. So subscribe our podcast series too. And then, thank goodness, COVID has mellowed down and there's an opportunity for us to interact and meet. So there is a whole host of meetings and conferences related to AI and healthcare. You can go to our website, look in the conferences section, and you will find the listing over there. And you could go to the meeting website directly from there and register, and hopefully we can connect there too. And every year, for the last 4 years, we have been publishing our year in review for the AI and healthcare publications. And there has been a tremendous growth in all those specialties. And of course, today we'll be talking about perioperative, which cuts across anesthesiology, critical care, and surgery. So 3 different domains, if not more. And we will learn from our wonderful speakers about their wonderful work. And to introduce them, briefly, you can find their more information on the website itself. We are privileged to have Dr. Mathis, Dr. Najarian, Dr. Gryak, sorry if I mispronounced it, Dr. Maheshwari, and Dr. Khanna, who are joining us today. So with that, I'm going to invite our speakers, Dr. Mathis and the team from University of Michigan. to go over their presentation. Thank you.
Fantastic. Thanks, Piyush, for that intro. And again, it's a pleasure to be here. I'm just looking at past speakers, in awe of some of the speakers. I saw you've had Maxime Cannison, David Oyang. I think these are all the types of clinicians and informaticians, machine learning experts that I aspire to be. So it's an honor and a privilege to speak to this audience on this stage. Can everybody see my screen right now?
Yes, we can see it and we can hear you.
Perfect. Okay. So what I'll be speaking about today is a recent publication in anesthesiology entitled Prediction of Post-Op Deterioration in Cardiac Surgery Patients, using both electronic health record data and, interestingly, physiologic waveform data. This was a project that it took many rounds of review and was a labor of love and also a Herculean undertaking that I take little credit for. I give a lot of the credit to to Jonathan Gryak and Kayvan and the programming team for being able to just curate and work through all of the data that was necessary to pull together to do this project. So I kind of the spokesperson here, but at the same time, it's the work would not have been possible without an incredibly talented team. So I'm so grateful for their contributions to this project. I have work. My institution is supported by grants through the NIH, and I know Jonathan, his work at this project had also been supported through a grant from the Department of Defense. But we don't have any personal financial conflicts of interest, and there's no off-label or investigational use drugs in this presentation. So this was the publication. I just include a QR code for those attending right now or watching on YouTube to be able to quickly go to this article recently published in anesthesiology. And you can find out more about this publication there. We'll go over, as I know is common during these talks, is we'll go over a little bit of the clinical perspective, as well as the methodologic perspective of this project. They're both, you can't have one without the other, and so we'll break it down into those two sections. And if we have time at the end, depending on how our time is going, we can also have a discussion on a couple issues that we encountered along the way that are translatable to other projects using machine learning AI-based techniques in healthcare. So with that, we'll jump into the clinical focus, which you'll hear from me about. So it's, I may not have to convince this audience that complications after cardiac surgery are common and costly, but here are just some basic figures. Depending on how you define complications, it can be you can be much higher than 20% if you depending on your scope and definition of major complication. But they're common, they're expensive, and they will dramatically impact health outcomes such as mortality, ICU length of stay, hospital length of stay. And so it's an important topic to study. Hemodynamic deterioration, which can be, after cardiac surgery, has varying etiologies. It can be, simply like an exacerbation of underlying pathophysiology that a patient has triggered by the surgical insult, heart failure, stunned heart from the cardiopulmonary bypass exposure. Or it can also more literally just be structural heart complications from the procedure itself. And so there's different etiologies, but regardless of the underlying cause, all are important to study. Clinically meaningful events that, if we can intervene early upon, may drastically improve the outcome for the patient and the costs to the hospital. There's a whole bunch of, with the exponential growth of electronic health data, beyond just the ICU nursing flow sheet, we now have data such as physiologic waveforms, which are largely unused and outpacing the ability of an ICU team to be able to synthesize, interpret, and act upon this data. And so, the ICU team can't simply be acting upon all health data all the time. We're dealing with issues like cognitive overload. How do we digest the information that is contained within not just the nursing flow sheet, but again, physiologic waveforms. We have constrained resources. We only have a certain number of team members available at any given time, and we have equipment constraints as well. And the other constraint is that some of this is detectable. Some of the information is detectable by a human, and whereas our intuition will always be extremely valuable and can sometimes surpass, what's we can understand and appreciate the nuances of what's conveyed in electronic health data. And so there's always an ability for a place in healthcare for clinicians to be able to use their training and clinical experience to really understand the causes of hemodynamic deterioration or other patient health outcomes. But the reverse is also true as well, in that there's complex patterns within electronic health data that elude a human ability to detect impending adverse events. And this is where the machine learning AI methods that we'll discuss in today's presentation can take off and help again improve care, working together with clinicians to inform clinical patient trajectories and potential treatment strategies. So as specific to this study, this was a single center study done at the University of Michigan, ICU patients recovering from cardiac surgery, meeting a number of inclusion-exclusion criteria, which are detailed in the manuscript. We won't get into all of this right now, but suffice it to say, over 1,500 patients. We did a training validation cohort from 2013 to 2017, and then a temporal holdout cohort 2017 to 2020, just before practice patterns dramatically changed related to COVID. We specifically stopped our study at the height of when COVID was impacting the University of Michigan. Just keep that in mind. Again, there are notable inclusions, exclusions. We did want, as part of the study, to have patients to have PA catheter data available. This is our institutional practice pattern at University of Michigan. At least during the study period, over 90% of our patients getting cardiac surgery do have PA catheters. And we used this criteria not to obtain waveform data from the PA catheter. I'll explain that later, but just to enable ascertainment of a PA catheter-derived cardiac output outcome that was in our composite hemodynamic deterioration outcome. And we also wanted to make sure that each of these patients had waveform data available after 24 hours in the ICU, as that was the focus of this project. So again, with two key types of data in this project, EHR data, or basically what you would find on a ICU nursing flow sheet, along with kind of a pre-op H&P. So you have demographics, comorbidities, labs, an assessment of baseline LV function, some details about the surgery, whether this was a valve, aortic, multiple interventions, and then the ICU flow sheet as post-op data. We had 3 waveforms that we chose to study, specifically EKG lead 2, an A-line, and the PPG waveform from a pulse ox. We chose these 3 waveforms as these will be commonly available on all patients in an ICU for a majority of their stay. So we do have PA catheter and CVP data, but we ultimately decided after inspecting all of this data to not use those waveforms. Number one, just because they weren't available throughout the entirety of the ICU stay. They were, as patients were de-lined, these became missing data. And then also, we just found, and this is an issue that we can discuss later, that PA catheter and CVP waveform data, the real world data quality of waveform data tends to be not as good as the other waveforms, meaning that there's often situations where a CVP pressure waveform may be clamped. You might be infusing medications through that line, and or you may have an issue where the patient had a PA catheter that was wedged or pulled back into the right atrium. So all sorts of other kind of real world things that happen with PA catheter and CVP data that just made it too challenging to study. And we wanted to get a foothold with just the three more widely available, more trustworthy waveforms that we studied here. So importantly, hemodynamic deterioration was our outcome in this study. I won't get into all of the details here, but this is just just to illustrate the amount of thought we put into each component of the outcome. We wanted to focus on things that really are clinically meaningful, and based on my own experience as a anesthesia attending, rounding on patients in our cardiac ICU, these are the things that we felt in the judgment of a ICU attending might be clinically meaningful, very salient deterioration events. And we put a lot of thought into this and a lot of adjudication into each of these outputs. We also had some speaking of adjudication, some thought processes around what data we should not be looking at. And so one thing we did was we right censored data taped from patients at the time of decision for end of life care. So we don't want an algorithm that predicts a patient will deteriorate when you give them 10 milligrams of morphine. That's obviously a decision that indicates that end of life care might have been made. And so we right censored data at the decision for end of life care. And we also left censored data up until 24 hours post-op. And we did this for the reason that patients who were actively deteriorating at the time of ICU handover were not as meaningful an outcome. These were ICU team members that were already aware of a patient doing poorly and there was active resuscitation going on. But we found that patients who initially were doing okay for at least the first 24 hours, but then took a turn for the worse and deteriorated after 24 hours, we found those to be the more clinically meaningful, clinically important patients to go after. And beyond this too, we needed at least 24 hours of waveform data to generate predictions. So as a matter of practicality, we left censored patients until 24 hours post-op. And then, we had clinicians adjudicate these outcomes to make sure that we could trust them. And so this is sort of a flow sheet of how we looked at patients that had no deterioration events versus patients who had deterioration events. We did an extensive physician adjudication of these outcomes, removed false positives, false negatives, got to a final analytic data set of just over 1,500 patients, which was then split into a training validation set and a temporal holdout test set. Here is a figure that we spent a lot of time developing to be able to convey to a clinician reader all of the complex methods that we used to analyze our waveform and EHR data. And I'm not going to go into the full details here. I'll defer to Jonathan, who will get into some of this in the methods component of this presentation. But at a high altitude level, this was the pipeline that we used for handling data throughout the analysis. And there were a number of different transformations for the waveform data, including a tensor formation and tensor-based dimensionality reduction that were necessary to get it into a usable form for a machine learning-based prediction algorithm. Here's our kind of summary, high altitude level of our results. About 12 patients experienced at least one deterioration event. Many of these were low cardiac index, so a cardiac index less than 2 liters per meter squared per minute. But a number of these were other things like a new inotrope being started, a inotrope being escalated, meaning an inotrope that had a dose that was doubled, sustained hypotension, new vasopressors. All of the outcomes that were in our composite outcome had some substantial contribution to our composite outcome. Here's the major takeaway figure from this study. And what we wanted to do is we wanted to look at in this study the individual contributions of electronic health features to a prediction of an algorithm using predicting the postoperative deterioration event. We want to look at a model that only used waveforms, and we wanted to look at a model that used both, and we wanted to see, and again, there's a number of ways you can measure performance. To some degree, which way you pick is arbitrary, but just to use a widely accepted performance statistic, we use the C statistic in this figure. And I think I'll point out, two main things I think that we found were that, yes, waveform features contributed. A model using waveform features plus electronic health features performed better than a model using either modality alone. But when you compare them head to head, it's really the waveform features that drive a lot of the performance of the model. So that's observation number one that we made. And observation number two we made is just a matter of practicality that I think we'll have to face as clinicians dealing with AI-based algorithms in healthcare, is that our models had a substantial drop in performance over time that's not attributed to any overfitting. Here are the confidence intervals around these, but probably as our best determination was, this is representative of data set shift, meaning clinical practices changed over time. The way things are documented in the EHR changes over time, and the model became detuned in that way. And so this is just being transparent and honest about how temporal validation can lead to a drop in performance attributable to data set shift, but that's what we observed in this study. So from a clinical perspective, the main conclusions again were that the waveform data did drive a lot of the performance of this model, although a model using both EHR and waveform data was superior to either alone. And again, there's this issue of data set shift, a drop in model performance over time, which is going to be a core challenge of any healthcare prediction modeling problem. Couple limitations, but just to be on time, I want to get to Jonathan's part, but we can talk about these later if we have time. So I'll stop there and I'll turn the floor over to Jonathan Gryak, who can get into the methods focus for this study.
Well, thank you, Mike, for that great clinical introduction. And also thanks to everyone from the BrainX community for inviting us to talk. I should also echo that, what makes these types of, biomedical informatic projects successful is, the tight collaboration between the clinical side and the methodology side. And so, we can put all sorts of fancy techniques into play in this context, but without having clinicians to partner with to understand the problems that need to be addressed, we can't really make meaningful progress. So it's really a true collaboration, and I thank Mike for that. So, Mike has shown this previously. This is the overall machine learning pipeline, and again, there's sort of two horizontal arms that we see here. We have this much larger one on top, which is the physiological data processing, and again, you can see that there's a lot of steps that are involved in trying to extract meaningful, sort of, as Mike called them, subclinical features, right? So, of course, there's so much knowledge and experience that goes into the clinicians bring to the table in trying to understand a patient's condition. But again, there's things, whether it's waveforms and imaging and other kinds of modalities that we as humans are just not equipped to be able to see and glean with our own eyes, or be able to do, calculate rapidly. And so all of these sort of different steps in this algorithm are, designed to try to pick out meaningful information from these waveforms. And so again, I'll talk about some of these steps in subsequent slides, but in general, what happens is that, these waveforms, we capture information at different scales and using different types of signal processing techniques. We then put them into this format, this tensor format, which enables us to sort of have some kind of relationship between the extracted information at different scales, and allows us to summarize that information across many different patients. And because we're extracting lots of different features, we then have a challenge of, how do we handle the cursive dimensionality. And so we want to reduce the number of features that would then go into the model. So those reduced features are then combined with some EHR data, which are put into multiple models, and then ultimately we're producing these predictive models for hemodynamic decompensation. So next slide, please, Mike. Thank you. And so one of the ways in which we're trying to capture information at different scales is this methodology known as taught string. And, you can think of it just as a piecewise linear approximation of a function. In this case, this is an ECG signal. And what it's parameterized by this epsilon, and what that enables us to do is sort of pick out different trends in the signal, different morphologies, different shapes across different scales. So moving from left to right in this slide, we have a segment of ECG, and we see that as we go to the right, the epsilon value increases, and we sort of get coarser approximations of the signal. So the idea is to be able to, in to help smooth out some of the noise. It's very, tiny variations of the signal, but then also to potentially pick out not just sort of the R to R, intervals, but potentially look at other changes in the morphology, and to do that at different scales, in the waveform. So again, one of the challenges is, why would we take a tensor approach? So I think it's instructive here to think about what we typically do in machine learning. So we will usually take whatever kinds of information we have and we put it into a feature vector, right? So there's a big long list of generally numbers and some encoded categorical variables. And so in that sort of feature vector, right? We're not able to ascertain sort of this potential relationship that may exist when we take all of our information and flatten it into this one-dimensional structure. So in this case, we see in this vector here, we can think of that being a binary vector, and the whites are, 0 and the blacks are 1. But if we looked at what this came from, we would see that this is actually a two-dimensional picture that corresponds to the letter A. And so when we look at this picture, we immediately see that there's a relation. We know what this is. It's an A. We see the structure behind it. But by taking this and flattening it down into a one-dimensional vector, we're sort of losing all the spatial information that's implicit in this image. And so, tensors are a way of being able to sort of preserve this kind of information in our data. So again, there's many kinds of data that come naturally as tensors. And so one of the best examples, or easiest one to think about, is just a color image. So we have a two-dimensional array, but it's actually comprised of 3 different color channels in a typical red, green, and blue. So we see this picture of building at a Cleveland clinic, and we have sort of 3 different channels. So this is a 3-dimensional tensor, and that has height and width, and then the 3 color and channel intensities. And there's all different other kinds of data which naturally come in a tensor format. So if we think about a video, color video, it's a 3-dimensional tensor per frame, and then it's that over time. So it's actually 4-dimensional data. Other common medical data like a CT volume or MRI, those are also 3-dimensional. And even if we have a joint probability distribution, those will, as long as we have 3 more variables, that is best represented by a tensor, in particular a symmetric tensor. So these are naturally occurring in data analysis. So we want to sort of capture information in the waveforms at different scales, and then put them into these sort of tensors. So then we can sort of relate the different scales and together. So what we did in this particular project is that for a segment of signal, and in this case we used 15 minutes of signal, we broke that down into 3-minute sub-windows, so 5 windows of 3 minutes. And then in those sub-windows, we performed taught string analysis at 5 different epsilon values. So we're getting 5 different approximations of the signal in that window at different scales. And then ultimately from those approximations, we extracted 6 different features, and those are related to the morphology of the signal. It would be the number of line segments that are in that particular window, the number of inflection points, how many times the signal is changing its curvature, and so forth. And so ultimately from a segment of waveform, we're taking out a 3-dimensional, a 3rd-order tensor of 5 windows by 6 features and 5 epsilon values. And so once we have those signals, those tensors created per each patient, what we do is we take for each of the modalities, remember we had 3 different waveforms, we had ECG, we had the art lines, and also the PPG. We take the tensors that were formed for the patients that are in the training set, and we stack them into a 4th order tensor. And we use this well-known algorithm known as CPILS, and this is just a tensor decomposition method. So it's going to take that large tensor and break it down to a number of factor matrices. And these factor matrices, if you kept them as they were, as they output by the algorithm, you'll be able to reconstruct that entire tensor. But what we want to do with this is to actually try to use the fact that there should be similarities in this data across patients, and we want to be able to capture that in this tensor, and then actually reduce the number of features that we're going to use. And so what we can control that by picking a rank. And the rank basically says how many columns of these factor matrices do we want to keep. And so in our project, we chose a rank of 4, and this across all of the features and all the waveforms that we extracted information from, we wound up initially having about 5,000 features, and then choosing a rank of 4. Through this process, we reduced all of those features down to about 430, so about 90% or so reduction. So significant reduction in the number of features available. So yes, next slide. Thank you. And so, as Mike had discussed, we had a validation training set, which was from 2013-17, and a temporal holdout set, 17 to 20. And so these data sets were then put into various machine learning models. Hyperparameter optimization was performed on the validation set, and then we wound up, again, doing multiple shuffles of the data and then applying these to the test set, which again was a holdout, and that came solely from the temporal holdout set from 17 to 20. So again, there were multiple standard models that you'll use in any kind of biomedical informatic application. So SVM, support vector machine, random forest, naive Bayes. And we had one that we had developed previously in our research group known as learning using concave and convex kernels. And so the idea behind this methodology is that it will look for a kernel, meaning just a function, a similarity function, and it tries to learn a function on each of the features that are in the feature space in our input data. And it tries to then find how best to discriminate on a per feature level between the classes, and then it aggregates that information together and to make the ultimate decision whether, say, someone is deteriorating or not. And again, we've used this in other contexts, including fibromyalgia as well as in food allergy, and it seems to work well when we have either very noisy data or data which is sort of weakly correlated with outcomes. As I mentioned previously in this project, we took our data and we sort of shuffled it 101 times. Again, this is trying to be able to reduce sample bias in our models. And then again, once we took each of those sort of permutations of the data set and then applied them to the holdout set to then get the final performance metrics. And these are those metrics for the 8-hour interval. We had tried, we constructed models going from half an hour up to 12 hours in advance. But these are the 8-hour ones here. And again, you can see on the top, we have the initial results for the training and validation set. And we have, again, roughly for the random forest performing the best with regard to the C statistic or area under the curve, about 0.8. And again, pretty relatively tight confidence intervals with the 95% confidence. And then we have below that the temporal holdout set. And again, we do see a reduction in the performance. Again, I think as Mike had described, one of the challenges to think about anytime you're doing this kind of analysis with retrospective data is that the data is being captured in order to advance clinical care and to perform clinical care, and not necessarily expressly to capture this particular phenomenon. And so it's sort of inevitable that as time goes on, practices change, standards change, and so there is going to be a sort of shift in how the data is ultimately captured and how each of the particular features is represented. And so we do see that reduction here. And again, this is not something that is specific to healthcare. It's also true in all other domains. Most companies who are using who are using machine learning models in practice wind up sort of having these automated systems where they measure the performance of their models over time, and as the performance degrades as time goes on, they wind up then retraining the data to maintain performance. So this is something that is not specific to healthcare.
Okay, thanks, Jonathan.
Mm-hmm.
Just be mindful of the time. I guess I had additional slides just getting into the issues of algorithmic bias and data set shifts. Maybe we can save that. I defer to you, Piyush, but maybe we can save that for the end and we can get through Kamal's talk.
Yeah, I think let's go over to Kamal. I think there might be a lot of questions and discussion. I already have so many questions in my brain with that. So I think we'll welcome Dr. Maheshwari. But that was an awesome presentation. It just reflects on what you said. It's a Herculean task, not just from the design point of view, but from implementation point of view. So congratulations for the wonderful work. But in a related issue, which is part of what you described, the hypotension, the hemodynamic deterioration, Dr. Maheshwari has been leading the work in this across the world. I wanted to get his thoughts on prediction of hypotension in the perioperative period. So Kamal, over to you. Thank you.
Yeah, thank you, Piyush, for the invitation. And again, it's an incredible research which was presented earlier from Mathis and Gryak. This is the area where I believe that AI is going to show some promise and help patients. So that's the goal. We eventually want to not only make models, we have to improve patient care, and that is going there. So the topic which I picked up when Piyush asked, regarding this this talk, is that when we talk about prediction models, or even clinical deterioration prediction, which we talked last time, many times we take a lot of things for granted, a lot of assumptions for granted, and they modify how a particular model will perform, or a prediction model will perform, and and to some of the issues with Mike was alluding to, the algorithmic biases or data shift which happens. So those are real issues. And so my role is not as a machine learning engineer. My role is that when we are making these assumptions, when we are building these models, we provide some guardrails, and then actual test becomes is that when you really apply in the clinical situation and you change clinical decision making, and then you change some outcomes, right? So from that perspective, the one area which I've been working on is hypertension. So we talked about hypertension is bad, and then there was some numerous hypertension prediction models which are available in the market at this point of time, and my goal is to highlight a few of the issues, issues from the perspective, not that they are bad, issues from the perspective that we as clinicians and scientists need to solve it. So the first thing which comes out of play is that, oh, you're predicting hypertension, everybody's predicting hypertension, but what is hypertension, right? So as in the last talk, we talked about clinical deterioration, which is defined as hemodynamic alteration, and hemodynamics alteration in which blood pressure is part of it, and lower blood pressure is hypertension. So that's how we're going from the logic. And hypertension from clinical definition point of view is that any pressure which your organ perfusion is compromised. Okay, so but then when I ask the machine learning people, can you build a model? It's like, okay, no, define objectively what is hypertension. Okay, we go to the next level. We go to the next level, like the perfusion is compromised, but compromised to the level that it is causing organ injury. Like which organ injury? Okay, take an example, kidney injury. And then, so this is how the question evolves, that you have to define your outcome, what you're predicting. And in fact, at least the reason for the variance in a lot of prediction models, which we're seeing right now, is that there are multiple definitions of hypertension. And that's the work which is evolving right now. Just to give you a little bit more idea regarding organ perfusion. So perfusion is flow per unit, and that is like a lot of physics goes along. There's organ level autoregulation, so one pressure reading may or may not suffice. But the goal of science is to simplify things. You can simplify the definition and simplify the logic. What you say is low blood pressure will leads to poor organ perfusion, which leads to complication, and leads to complications like you define acute kidney injury or mortality or what have you. And so in the last 5-10 years, that's the work which have happened to make this logic right. And multiple publications have come out to be. But the picture which on the right side of the screen is showing that blood pressure gives you information only on the red part of the screen, and which is only 15% of the whole circulation. So you don't have any other information about other part, and you're making a judgment on hemodynamic compromise or clinical deterioration based on just the so-called red part, which is 15%. So that also kind of complicates that why some models may or may not work in clinical setting. Nonetheless, complication per se is our goal. Prevention of complications is our goal, and because the third leading cause of death across the world. So all the literature, if you kind of summarize till now, this is the recent meta-analysis which we worked on, and we picked it, this is just to give an idea how much research have gone into to show that hypertension is bad and which organs can be involved. So it is well known that you should prevent hypertension, and hypertension prediction becomes a part of that solution. Then the next question also comes is when you are saying what is hypertension, is that the signal which you get. So now we would delve down to, okay, even if I define that hypertension is less than 65 millimeters of mercury, now the way to calculate this hypertension exposure, if you will, is all different. For example, there are different mechanisms and modeling technique in which you show that the volume of this exposure, right? It could be just the minutes under certain threshold, which certain threshold we defined, or you have other mathematical things which gives you an idea of depth and duration, both depth, which is the area on the curve, and you have to adjust for the time. So it's just complicated at that level. So again, still at the level of definition of hypertension you define becomes important. More recent work has come down to the fact that if we as clinicians believe and researchers believe that is the depth which is more important than duration, right? How can you prove that? So recently, one of our colleagues from Europe, they put out this paper in which they weighted the depth of a hypertension more in one model and duration of the hypertension in one model, and then try to explain that depth appears to contribute more than the duration of the hypertension. So all in all, it is one exposure or one thing which we are trying to predict. So that is also is so complex by itself, and that tells you that the problem which we're trying to solve, with the hypertension or hemodynamic alteration, there's a lot of room to work here. The few things which have been done, right? So you make models that in certain areas that you can say multiple levels of hypertension in different areas, you can pick up those signals to simplify, because ultimately you have to simplify. And it is well known that it's not about a particular threshold, but it's just the increasing amount of hypertension exposure if you will, both in depth and duration, causes more problems, and they are different in different organ systems. So that leads to us that we were talking about hypertension prediction, but with that background, if I tell somebody that hey, go predict hypertension, it's like, it is a little complicated, right? But let's say we have some definition what we are trying to predict, and a definition which we have used is like blood pressure less than 65 for more than a minute, okay? Despite the simplification. So I'm taking responsibility of simplification, but that becomes a starting point. But that is also not an answer for a clinical problem, because prediction is the component of the whole kind of a use case, if you will, in which prediction should lead to something, which is some diagnosis, should lead to something that you are able to correct, and then it should lead to something that improves outcome. So presenting an isolated solution for just prediction also doesn't help anybody, and that is the problem which we are getting into now. So that is about the issue one, that, okay, your problem definition is complicated in medicine right now. These are not as simple as, um, I'm not going to simplify, dog versus cat, but it is still much more complicated than that. The second issue which we have dealt with is that how you develop these algorithms and how you evaluate it. So these are separate things. Development, basically, you have a test model, you divide the data into this and that, and you use multiple assumptions, you define your yes or no classes, and these are all a lot of assumptions, right? And you have to be transparent about it, but they're guided by the clinicals, input, but also guided by what an algorithm can or cannot do, right? So if you're making a classification model, you have to define yes or no, like what is your right, what is your wrong, otherwise don't work on that. So that development part is complicated, and sometimes when we say, oh, this algorithm performs well, that is mostly from the development point of view, that you presented some AUC, some precision recall statistics, and you say, on the data, when I build an algorithm, the algorithms work well. And that sometimes people take as an evaluation. I'm talking about clinicians, right? So this is machine learning for healthcare for everyone. And then the evaluation part is also both on the data, on the in silico evaluation, but also clinical evaluation. And sometimes that gets confounded in our jargon, that when people talk about, oh, my algorithm work well, so work well where? So that is the question. And for example, you have predictors which were chosen, like in the last talk, we talked about, you can use EHR data, you can use waveform data, and how you utilize them, is guided by us, and that can produce a bias within the system. But let's say a predictor or alert which led to some outcome or event, right? So that's the basic model which is used. But the problems which happens is when we try to work on it is that the choice of predictors, the choice of the data which you use actually is causing a bias, be it a measurement bias, this could be a systematic bias, there could be algorithmic bias, because you chose certain definition of parameters into what needs to be done. And in medicine, what other things which happen is interventions. You make a prediction for a particular outcome. In ideal world, let's say there was nothing happen in between, your prediction works well, and the outcome happened, your model is performing well. But nobody is preventing an intervention. So you predicted hypotension, but somebody gave a drug which prevents hypertension in between. So would you call that prediction good or bad, right? Because at the time when the prediction was made, nobody knew that intervention will be done. So these are called confounding clinical interventions. There are a few groups which have done research on that, and especially from Hopkins, and how to deal with this confounding clinical interventions in our field of clinical deterioration and hemodynamic predictions is complicated. Should you remove those segments? Should you keep those segments? How does that influence the prediction performance? It is complicated at this point of time. And outcomes, and we talked about, right? Like if your outcome is hypotension or event, right? The definition I chose for simplification is this, but I gave you a background that why we came to that thing, and that may or may not be true, right? And that could be different by different groups and different prediction models. So it is difficult to compare two prediction models now when this complexity is there. So just to give an example of, like, even if you are talking about hypotension or hypotension prediction, right? The context is important. That in the context you're saying, I'm talking about operating rooms, you have a balanced anesthetic, which has its own parameters, balanced anesthetic. You have stable surgical condition, that they have their own set of parameters. If those things are true, then you can predict, okay, hypotension or hypertension prediction is good or bad. But then interventions. So the question is, these interventions can happen, or these are the result of your predictions, and they impact clinical care. So the clinical intervention, by definition, becomes very complex topic within this prediction. This is just an example that, when we have a raw data, and we don't have the data regarding, for example, EHR data, and we don't know whether the vasopressor or some interventions were used, we make models, right? We make assumption. Oh, if there's an increase in certain value, like for example, here is a blood pressure value about 5 or 10 units in certain seconds. These are all assumptions. And then we'll say, oh, there's a potential intervention. And we will deal with these segments differently compared to other segments. And you kind of analyze your model performance with or without these kind of segments, and do multiple sensitivity analysis. But the bias comes from the fact that I made it up, right? Because it makes clinical sense, but somebody might choose something different and come up with a different prediction model, a different performance. So use case which I use it because I worked the most in my research with the HPI technologies developed by Edward Life Sciences. So on the right upper corner, you have HPI 86 by 100. This is the prediction that 86% probability of hypertension in coming minutes. And you have rest of the data, and mostly it's based on the arterial pressure waveform, only single waveform based technology. And so far it's studied well, from the initial paper. There are multiple clinical trials which have happened, including randomized clinical trials, which is now using this technology. So well researched. Just some example of research which can happen in these kind of things. So if you build a model which is the original data set, you have tested, validated, presented your AUCs and other good stuff that, oh, it works, please use it. Then people can take the same algorithm and use in their own data set, which is external validation. And they can also say that, okay, you are predicting using arterial pressure waveform, can we use some other things and then compare the prediction performance? So in this paper, this is just an example that you compare one technology prediction model versus other ways of predicting that event, which is hypotension. And the AUCs, I mean, it does give some comparative idea, but not necessarily it's the best way of comparing different models. One of the ways which we have evaluated these models is rather than AUC curves, we have done the event rate analysis in addition to the the AUC curve, because you want to see a forward-looking. The backward-looking ROC curves, again have a bunch of assumptions. The forward-looking event rate analysis, that if you predicted something going to happen, and did it happen or not, right? That's a simple thing without any assumptions, with all data and everything. So the event rate analysis, I think, should be presented for all these evaluation techniques, and rather than just the precision recall or AUC curves, which are presented. Then the ultimate test is the randomized clinical trials, that you actually deploy your solution or prediction model on patients in clinical care and see if what you wanted to do happened or not. So despite all the good research which has happened from HPI, here is the example that one trial, which is 50 patients on JAMA, showed a lot of reduction in hypertension, and the trial which we did, which is 200 patients, we did not see reduction in hypertension, right? And then the question is like, what is the problem? And the problem is mostly like, did you intervene post-intervention? Did you actually do something or not? Or was the alert followed or not? And how do you deal with this thing? Like, you say this is a bad algorithm, or this is bad clinical care, or where does it fall into the clinical evaluation point of view? That's an important question. So I think, and the last thing which I would say is that the issue 3 is like, we should not see all these models in isolation. When we say that I'm building a prediction model for something, right? We should think about what is this impact, potential impact on clinical care once you deploy, because anything is going to influence decision, right? It's going to, even if you say you don't have to do anything, but the bias creeps in. Like, if you give me any information, I'll change my brain. Something will happen, subconsciously or subconsciously. So any modeling which comes in eventually should come as an end-to-end solution, which is focused on patient outcomes. That's how the evaluation of algorithms should happen going forward. So, I mean, based on my experience, at least in hypertension and hypertension prediction, What I see is a multiple definition of hypotension is an issue, which the second is the way of development, because we make our own rules, and you can challenge my rules are bad, I can challenge your rules are bad, and so and we can keep fighting about it. But the development part is not as structured. I don't think it needs to be structured also, because ultimate thing is you have to deploy on the patient, you prove your evaluation or prove your performance at the clinical evaluation level, not at the level of your AUC level. And that's how I think it's going to go. And hopefully going forward, our early work, which is happening into this prediction of various events within in-hospital system, which are very dynamic. People present end-to-end solution rather than an isolated models. So that's where I'll stop.
Thanks, Kamal. That was awesome, especially like outlining some of the translational aspects, or rather starting with the hypothesis building and going all the way to the translational aspects. There are a lot of challenges to overcome, and both Mike Mathis, Jonathan Gryak, and Professor Najarian, and yourself, you guys have been leading this work and have done some awesome groundwork in this, and hopefully we get to see a lot of this implemented and making an impact over here. So we have a small group, so if anybody has any questions, please bring them. I did post that question about the impact of a higher frequency. I know we did dimensionality reduction to counter, to first of all deal with the amount of data in a better way, but do you, especially compared to EHR, where you might get like 1 hour, or sometimes on the floors it's 4 hours, 6 hour data. When you get into using a multimodal approach, your thoughts on how to manage something like that, where it's not just one type of the model, that's one type of the data that is going to be the main part. And secondly, when you have the EHR data and waveform data, I mean, there are overlaps. So how do you account for those? Some thoughts on that would be great.
Yeah, and I can let Jonathan weigh in here as well. When I think about, like I guess the first part of your question, like the frequency of the data, and in kind of what is a fair comparison between waveform data, which you can get 60 to 240 data points a second, versus an EHR data source, which is in usual ICU flow sheets, you have potentially at best like an hourly flow sheet in the ICU. And I think I kind of think of this from a clinical perspective. You don't, I guess, necessarily need to create any artificial restriction. You should just have the data that we have available at the bedside is what should be fair game for the algorithms. And so I think of course, if we're not using again 60 to 240 hertz waveform data that potentially captures a lot of subtle nuances in patient health that a nursing flow sheet might not have available. I think if we're not using that, I think we are missing out on a lot. And there is, so I think to compare them head to head, I think it's fair if you're just restricting it to the data that would potentially be available to a clinician at the bedside in real time. And obviously there's a lot of barriers to implementation of that kind of thing, but it's at least theoretically possible. So I guess that's kind of how I think about the frequency of the data. Jonathan, you have any thoughts there?
Yeah, I would just say that it's less about frequency and more about finding a way to capture more of the variation in physiology using different modalities. And so again, if we're using a heart rate or other kinds of just basic vital signs, again, you can think of that as some kind of aggregate statistic over the physiology, right? I mean, that's obviously a coarse, gross simplification, but in some sense, that's what it is. And so what we're trying to do is it's not so much that we have high density waveforms, although that helps. It's more that we have we're sort of a bit closer to the underlying physiology than those, kind of, static numerics are. And that if you can use some of these, techniques that you described, I talked about taught string, but there's also some wavelet and some more, sort of fancier signal processing techniques that were employed. You're able to pick out more pieces of that data that goes beyond what is captured by that, what you see at the sort of, vital sign level. And so I think that's what the utility is, more than just the frequency of those other modalities.
Great. I do see Dr. Tandon is here, one of the pediatric cardiologists. He has his hands up. So Animesh, questions or comments for the team?
Yeah, hey, this was really exciting work, and is a field which we struggle with in pediatric cardiology, as Dr. Mathur mentioned. My question was about, like, there have been, right, like when you're doing these waveform analyses, there are known potential badness that exists in those waveforms, right? Like ST segment elevation or T wave inversion or other, like gradually declining oxygen saturation for our patients, right? Like there are known clinical patterns that exist in those data that are some of those things that we look at when we walk by the bedside and say, hey, how is this patient doing? How does the TOTS, but what I've always struggled with is, right, like, how do we incorporate both of those timescales, right? Okay, how do you look at, all right, ST segment changes changing over time, but then also, right, over the last 2 hours, this patient's sats have gone down, or their heart rate has gone up, or their variability has gone down, right, and they're maxed out and they're tachycardic. How do these approaches that you used kind of put those kind of known clinical insights into that model that you're building?
Sure. Well, some of that was done through, we didn't specifically look for some of those, ST elevations or things like that. And that's something that could be introduced. And again, there are, libraries that will, try to detect those kinds of things. But I think what we're trying to do is, while there may be known clinical, relationships between, say, ST elevation and some other, arrhythmia or cardiac, dysfunction, I think for some of the other deterioration events that we have, we may not know precisely how those relate to those types of events. And so, one of the, again, advantages of the, sort of machine learning approach is to say, like, well, we have this data, we have our outcomes, try to find some kind of mapping between them. So it's certainly possible that we could incorporate those kinds of explicit detections in addition to the sort of just more information theoretic things that we took out of the waveform. So we did, just in terms of looking at trends over multiple scales or look back periods, we did in the EHR have different periods of sort of retrospective data. So looking at data of like changes in vital signs over, what was it 4 hours ago? What was it 8 hours ago? And those were incorporated there, but we could have done that with, similar with sort of explicit detection of certain known morphologies in like an ECG, for example. That's something that
I think in relation to Dr. Maheshwari's talk, like, and some of the challenges in implementing, right? So if your algorithm says, oh, this person's going to have a decompensation in 2 hours, but we don't know what kind, and we don't know what to do about it, then it's not super actionable, right? Like, and like, all right, well, what am I going to do, right, to this patient at this moment to stave off this oncoming badness? So, I think that's been one of the challenges in our field, where there have been a few of these ICU-based deterioration detection algorithms. Some say that they use a underlying physiologic model. Some say that they just look at the data, right, and don't have any underlying assumptions, but then it's harder to interpret for us. Like, all right, well, what does this mean and what do I do about it? I mean, this was really impressive work, and work we need to do in the pediatric cardiac ICU as well, where we theoretically think that some of these waveform metrics are more indicative of underlying physiology. So thanks.
Well, thank you, Doctor. And that's again validation of the impressive work by the team. And probably going to leave the last word for Dr. Maheshwari. Like, where do you see this 5 to 10 years from now? Like, what would success look like? And what's your view for that?
No, I think this is definitely a pretty exciting field, and this is one of the very few areas in healthcare where machine learning and AI will produce actually real actionable insights and will change patient care and in real life. And I think the work will, and this will come within 5 years. It is not like 10 years down the lane, and I'm pretty excited about it, this field.
Well, thank you. And thank you everyone for joining us. Exciting presentations, exciting discussion. For more, please follow us through our website, join us on our LinkedIn group. We have our live channels, sessions, so please join us for that. Subscribe to different content mediums. So thank you everyone. Thank you speakers. Thank you for the great questions. We'll follow up. Have a good day.